Thank you very much, Mr. President. Thank you to the Association for this opportunity to present our work. I'm going to talk to you today about mortality in high-risk emergency general surgical admissions, as you've heard. As we all know, emergency general surgery forms a huge portion of our workload. In fact, over 600,000 admissions per year in England. Despite the fact it's half of the general surgical workload, it actually makes up 80 to 90% of deaths in this area, in general surgery. And there's been for some years some concern about variability in the quality of care for these patients. And this has led to various publications from NCPOD, from the Royal College of Surgeons, and also from this association. What we wanted to do was to look to see if this variability in the quality of care is actually translated into a variability in mortality outcomes between NHS trusts in England, and also to look at the effect of trust infrastructure and see whether that had an effect on mortality. So we looked at the hospital episode statistics database and looked at adults with non-elective admission to hospital over a 10-year period from 2000 to 2010. We selected patients based on their primary diagnosis on admission to hospital, and we used the gastrointestinal section of the International Classification of Diseases, 10th edition, and selected those diagnoses with a high risk of mortality, greater than 5% national 30-day mortality. And that left us with a group of high mortality diagnoses, but some of them primarily treated by physicians, things like hepatorenal failure, cirrhosis, and so on. And we therefore excluded those diagnoses based on the proportion of patients who are treated by surgical consultants. This left us with a cohort of 370,000 nearly patients with a mean age of 67 years. There were slightly more women than men due to the age bracket, and their 30-day mortality was over 15%. There was also a relatively long period of in-hospital care for these patients. As you can see, the age range of this cohort of patients was high. In fact, the most common age of admission was 80 years. And this gives you some idea of the diagnoses included. Clearly, bowel obstruction and gallstone disease were very common, and things like bowel ischemia had a very high rate of mortality. In order to compare different hospitals' outcomes, we needed to case mix adjust our data, and we therefore performed a multiple logistic regression using the factors you see on the left-hand side there. We used the Charlson comorbidity score to adjust for comorbidities, and the Carstairs score, which is based on patients' postcode, to adjust for social deprivation. And we then plotted the risk-adjusted mortality for each of the 147 acute NHS trusts on a funnel plot that you see here. We've included the mean mortality, as well as the 2 standard deviation limits, and with the broader dashed arrows, the 3 standard deviation limits. As you can see, there are, even at 3 standard deviations, quite a number of outlying trusts. There doesn't appear to be any evidence of a volume-outcome relationship here. Indeed, the trusts with the greatest number of emergency admissions have not performed particularly well. What is noticeable is that there is a twofold difference in outcome between the best-performing NHS trust and the worst-performing NHS trust, between 9 and 18% mortality for these patients. So having seen this degree of variability, we then moved on to look at hospitals' infrastructure using data derived from the Department of Health's website. And these were the sort of things that we were able to get data on: hospital admissions and bed occupancy, the number of critical care beds in operating theatres, and how frequently trusts use CT and ultrasound scans. So we added these factors into our previous risk adjustment model, including the patient's demographic details. And although I appreciate this is a little busy, we found that hospitals in the highest group for bed occupancy and in the highest group for operating theatre provision had significantly worse outcomes in terms of mortality. And conversely, hospitals who had the most number of intensive care beds per 1,000 hospital beds, the most number of high dependency beds, and those trusts that performed the greatest number of CT scans all had significantly reduced mortality. And this slide just summarizes those findings. Higher mortality with high bed occupancy and more operating theatres, and lower mortality with extra critical care and CT scanning. So to try to corroborate these findings, we wanted to look at the outlying trusts and see if there were any difference in the provision of these structural factors at these hospitals. The outlying trusts at 2 standard deviations, the high mortality outliers you can see highlighted in black, the low mortality outliers highlighted in white. So in terms of operating theatres and high dependency beds, there was no significant difference. However, the better performing hospitals, those with low mortality, did seem to have a significantly greater number of intensive care beds. And they also did a significantly increased number of CT and ultrasound scans. So in conclusion, Mr. Chairman, we've identified a significant variability in risk-adjusted mortality for high-risk emergency general surgical admissions between NHS Trusts in England. And we've also, I think, identified some associations between the infrastructure provided at different NHS Trusts and the mortality results that they have produced. I'd like to thank my co-authors and the funders of this study for their assistance.